Good morning to all. So we'll have a case discussion today. Dr. Suman Pal, third year PG at MR Bangladesh will present the case on portal hypertension, and Professor Uyunnu Basu, who is professor and head of surgery at IPGM Hospital, will take us through the scenario. So Dr. Suman Pal, please start.
Okay, very good morning. Please start to share the screen. Okay.
Good morning, sir. I'm going to present a case on the total hypertension. I'm Shumon Bhat, third year pediatrician surgery from Imam Hospital. My patient was a 45-year-old lady, resident of Uttarpara, homemaker by profession, and presented in the surgical OPD with abdominal distension for 2 months and pain in the abdomen for last 2 weeks. History of present illness. Patient was apparently asymptomatic 2 months back when she observed abdominal distension, which was initially in the flanks and later progressed to entire abdomen. Distension was associated with pain, which was felt over abdomen, insidious in onset, dull aching in type, and gradually progressive in age. No aggravating factors, relieved on lying supine, and had no radiation or migration. Pain was relieved by some oral medication prescribed by local doctor. Patient gave no history of fever, chills, rigor, nausea, vomiting, altered bowel habits, jaundice, hematemesis, melena, bleeding per rectal, generalized body swelling, anorexia, weight loss, or dyspnea on exhaustion. Past history. Patient gave history of similar complaints of distension and pain 5 years back with similar progression, for which patient was admitted to a regional hospital where her distension was relieved by needle aspiration of abdominal fluid and was further managed conservatively. After discharge from the hospital, she had recurrent episodes of distension over a period of 2 years, which was treated with needle aspiration and oral drugs, after which she remained asymptomatic for a span of 2 years, during which she continued taking some medications. No history of any other chronic illnesses was there, no history of any surgeries, and no history of any blood transfusions. Personal history, she was a vegetarian, and no history of alcohol consumption or any other substance abuse. History of chronic intake of NSAIDs and diuretics was present. Normal sleep cycle, actively menstruating with regular cycle and normal flow. Family history, her parents have died of senility. Her 2 sons are healthy and no history of similar disease in her family members. Summary of the history. A case of a 45-year-old lady, non-diabetic, non-hypertensive, who presented with complaints of abdominal distension with dull aching pain over abdomen, with a history of similar complaints in the past, requiring recurrence of hospitalization and therapeutic ascitic fluid drainage, with history of intake of NSAIDs and diabetes.
Okay, we can have some discussion on the history presentation.
Yes, so the case is you presented is a case of ascites.
Yes, sir.
Then we have to give the differential diagnosis of the ascites.
Yes, sir.
From the history, what is the impression? What is the likely cause of ascites in this patient?
Sir, the cause may be due to, as it is a case, presenting with ascites, it may be due to some liver causes or some infective, some causes that is generated from systemic, like from cardiac cause or from hepatic cause, or it may be some infective like tuberculosis.
So, what are your possibilities of ascites? Number one is,
sir, cirrhosis, maybe cirrhosis of liver.
Okay.
And it can be because of disseminated tuberculosis.
Disseminated tuberculosis. Okay.
Or it can be due to some cardiac cause.
Cardiac cause.
Or it can be due to some renal causes.
No malignancy.
It can also be due to malignancies.
So malignancy is one of the important cause. Okay. So now after how to assess the ascites? Now you tell us the how do you assess this patient?
You could pass on the examination.
So physical examination. Patient
Yes.
was examined. Patient was examined in well-lit room after proper consent was taken and in presence of a female chaplain. Patient was laid supine, properly exposed, and all procedures were explained. Patient has an average BMI 19.7, ECOG score 1, vitals afebrile 72, pulse is 72 beats per minute, regular, normal volumic, no radioradial, radiofemoral delay. BP was 128 by 80 mm of Hg in right arm in supine position, respiratory rate 20 cycles per minute, and no pallor, icterus, cyanosis, pedal edema, lymphadenopathy. Clapping was grade 3. Local examination of abdomen, inspection revealed generalized distension of the abdomen. Skin appeared dry, stretched out, and has no incision, scar, or scratch marks. Umbilicus is displaced downwards and everted. Visible dilated superficial veins in the epigastrium and paraumbilical region was seen. All quadrants move equally with respiration. No visible pulsation was noted. Palpation. On palpation, normal temperature was noted. No tenderness on superficial palpation. Reducible umbilical hernia was present. Inferior margin of the liver palpable on deep palpation, which was non-tender, smooth, and firm in consistency. 3 cm below the right costal margin in mid-clavicular line and 5 cm in mid-axillary line. Liver surface was nodular. Liver span was 9 cm in the mid-clavicular line and 12 cm in the mid-axillary line. Spleen palpable up to umbilicus, which was non-tender. Surface was smooth, firm in consistency, and palpable notch along its edge. And fingers could not be insinuated above the swelling. It measured 19 centimeters from the left costal margin. Percussion. On percussion, fluid thrill was absent. Shifting dullness was present. Liver dullness, 6 the intercostal space in mid-clavicular line and 8 intercostal space in mid-axillary line. Auscultation, normal bowel sounds were heard, no bruit or hum. And on digital rectal examination and proctoscopy showed no abnormal findings. No supraclavicular lump was palpable. On systemic examination, CNS, she was conscious, well-variated to time, less person, no flapping tremors were noted. CVS, S1, S2 normal, no murmur heart, and respiratory system bilateral equal air entry with no added sounds. Case summary. A case of 45 years old lady, non-diabetic, non-hypertensive, who presented with complaints of abdominal distension with dull aching pain over the abdomen with a history of similar complaints in the past, whose physical examination revealed visible dilated veins around the everted and downwardly displaced umbilicus, massive splenomegaly with ascites, and a palpable liver, which was firm and had nodular surface. Provisional diagnosis of 45-year-old female with ascites due to decompensated portal hypertension.
Go previous slide. Go to previous slide. See, in your history, the important point you have mentioned, you have to mention either there is history of hematemesis or melena. If there is present, you have to mention, or if not present, you have to mention, because you have presented a case clinically, a case of portal hypertension. So portal hypertension is there is bleeding or not, it's very important, either hematemesis or melena. This should be one point. Number two, as you said, the diagnosis is your next slide. Next slide. Yes, you have made the diagnosis 45-year-old female with ascites due to decompensated portal hypertension. There is no term called decompensated portal hypertension. You have to write decompensated chronic liver disease with portal hypertension. Okay. So this should be your proper diagnosis. Now, so as you have given, this is the picture of a clinical signs of the decompensated liver disease, chronic liver disease with features of portal hypertension, as there is splenomegaly and this dilated superficial periumbilical veins. Now, what are your investigation you want to do for its confirmation?
And Dr. Basu, another thing, in summary, he should also mention whether there is other stigma of chronic liver disease, like spider nevi. He got some evidence, ascites is there. He should have mentioned other stigma of liver disease, means jaundice, spider nevi, palmar erythema. So these are the things you should mention, that because you are saying the decompensated liver disease, these patients may have other stigmas. All are to be present, not essential, but they are not there, that you examine for that.
Okay. Yes. Another point is rectal examination. You have to mention there is piles or not, because there is another feature of total hypertension.
Okay. So you have created a scenario of it's a decompensated chronic liver disease with portal hypertension. Why do you say patient has got decompensated liver disease? What are the features?
So this patient, 45-year-old female, is presenting with ascites, and this ascites.
You see there, if you say decompensated liver disease, there are some features of decompensation. One is ascites, agreed. What else are the features of decompensated liver disease?
So partial bleeding.
Yes.
And melena.
That is one part. Bleed. What else? What are the other features of decompensation of the liver disease? One is ascites. What else? Jaundice.
And splenomegaly.
Jaundice. Splenomegaly is secondary to portal hypertension.
Yes.
And patient may have features of hepatic encephalopathy. Okay. And other by investigation. Other evidence of decompensation by investigation. Why do you say patient has got portal hypertension?
Because this patient is presenting with ascites, and along with that,
why does ascites occurs in patient has got chronic liver disease?
Because of hypoalbuminemia leading to.
One is hypoalbuminemia, and what else?
And because of
and portal hypertension. Combination of hypoalbuminemia and portal hypertension leads to ascites. And other features of portal hypertension here.
Splenomegaly.
Dilated veins. You should have commented. You should have commented in a summary that dilated veins you are looking at has got a flow away from umbilicus. In dilated veins around the umbilicus, it should be flow away from the umbilicus, both above and below the umbilicus. Same. Because these differentiate this from IBC obstruction. Okay, and then you have splenomegaly. Agreed. Yes, Dr. Basu has asked, how will you proceed with this patient?
No, before that, I want to mention that the science of decompensation is right, as Professor Shah said, and as Professor Shah asked you why there is ascites in chronic liver disease. The most important part, the most important cause of ascites in chronic liver disease is portal hypertension. The hypoalbuminemia is very secondary cause, because hypoalbuminemia you can correct by giving the albumin and correcting the nutrition. So portal hypertension, what is the actually cause? How the portal hypertension produces ascites? Unless you cannot explain that as a cause of ascites. See, the cause of ascites in portal hypertension is not very much clear to everybody, but there is two theories. The theories of one is less absorption, and number two, oppositely more secretion. Like that, if you consider the the venous drainage of this thing, the peritoneum, you can jolly well understood that most of the peritoneum are drained by the portal system, not the systemic. And some are also systemic. So whenever there is portal hypertension, that means increase in the portal vein pressure, there is the peritoneal fluid is less absorbed, and so it accumulates and accumulates. Moreover, on the top of that, there is hypoalbuminemia. And later on, what happened, the systemic, the part or the veins of the systemic part, they are also in the collaterals develop, and there is shunting of the systemic and portal venous system. So there is more fluid is secreted in the peritoneal cavity. This is the basic pathophysiology of this thing. And what do you mean by portal hypertension? What do you mean by portal hypertension?
So increased pressure in the portal system. Increased pressure in the portal system.
Increased pressure in the portal system. So what is the normal portal pressure?
The normal portal pressure, sir, is 5 mm of Hg.
5 to 8.
No, so
5 to 8.
5 to 8 mm of Hg.
So
when it becomes above 8 mm of Hg, it is termed as portal hypertension.
Above 10. Above 10.
Above 10 is a definitely
Above 10. Okay. So now the part of investigation. So you have to prove 2 or 3 things. This ascites is caused by portal hypertension, and is there the diagnosis of portal hypertension. This is the main 2 causes of your diagnostic importance. One is for diagnosis of portal hypertension objectively, not subjectively, and you are saying that decompensated liver disease due to ascites. So that is another part. There are 2 main parts, other we'll discuss.
Sir, I will investigate the patient by doing some first blood investigations that I can go for, and some imaging investigations. Blood investigations will comprise with normal blood counts.
Ascites assessment. First, you assess the ascites. Which blood is important in the diagnosis of ascites?
Sir, serum albumin level we can check by liver function test, by which I can.
But Shuman, I think you should start with ultrasound. There is a basic investigation. Yes. Ultrasound will give a very good idea of all the ascites and some other very important information. So the approach should be your practical examination. So the basically approach will be to have a confirmation of the diagnosis.
Yes.
And then assess other ancillary investigation. I think the best thing the examiner is expecting is to proceed with the ultrasound of the abdomen. Because there are things we'll definitely do. They are part of workup, but the first investigation for ascites should be you find a ovarian malignancy. So everything changes. Okay, so the first investigation should be a ultrasound. So let's tell us what all are looking to say that this patient has got chronic liver disease. Because the point you said in liver palpation, I a little skeptical about that. If the patient has got cirrhosis, the classic liver palpation is the liver is palpable in the epigastrium. Liver is not easily palpable below the costal margin because in cirrhosis, the liver got shrunken unless there is a associated hepatocellular carcinoma change. Because you said it's 3 centimeters below the costal margin, but they're not very usual. The usual is to get the liver palpable in the epigastrium. The soft liver is not palpable, but a cirrhotic liver is palpable in the epigastrium. So that you said you're finding, but most of the time the liver palpation is like that only. There is not much of enlargement of liver in chronic liver disease.
And
So,
Suman,
yeah.
this point is to be noted, what Professor Shah said, that the liver is hardly palpable, or if palpable, it is palpable in the epigastrium. That means what? That means usually the cirrhosis, the right lobe atrophies and the left lobe enlarges. So usually we get the palpable liver in the epigastrium. Okay. Compensatory hypertrophy of the left lobe. This is the, so if 6 centimeter enlarged liver and with huge ascites is very unlikely. Okay. So, an important thing, what the professor has said, ultrasonography is the first investigation to assess ascites. There are many causes can be easily detected by ultrasonography. Number one, not only cause and exclusion also. And second point is, when you do ultrasonography, you have to aspirate the fluid. That is very, very important. Unless you examine the ascitic fluid, you cannot stamp as chronic liver disease. Maybe some chronic liver disease, LFT may be normal. Only the albumin may be low. Otherwise, the ascitic fluid assessment is the very, very important. Okay, these are the basic investigation first. And other investigation.
No, let him answer. Let him answer.
Say?
Let him answer what you look with ultrasonography in the liver, the other portal vein, the spleen, and
what are the findings? Yes, what are the findings he is expecting?
You are doing ultrasonography and patient got underlying cirrhosis with this, and the clinical finding you already said. So, what are the things you see in ultrasonography? How is the liver?
Sir, the ultrasonography will depict the liver size of the liver.
There is a classic description they give in the liver for cirrhosis. What is that? Liver has got a normal ecogenicity
and loss of ecogenicity.
Yes, there is alteration of ecogenicity in the liver. That is because of fibrosis and nodule formation. So the liver will not be uniformly ecogenic. There is altered ecogenicity of the liver, number one. The liver size may be shrunken. You said it is enlarged, that you corroborate, but most of the time the liver is seen to be shrunken. And if you have a macronodule in the liver, the ultrasound can demonstrate that macronodules. The small nodules cannot be picked up by the ultrasonography. Then, what about the portal vein evaluation in ultrasonography?
Size.
Yes. So you can size. What size of portal vein you say is normal? When you say portal vein is dilated, that happens in portal hypertension.
More than 7 mm.
Up to 10 mm, portal vein is a normal portal vein diameter. A portal vein diameter of 13 millimeter or more indicates that it is a definite portal vein distension because of portal hypertension. And in some extrahepatic portal obstruction, you can find that main portal vein is not seen. Instead, there is a portal cavernoma. You can assess the spleen. You can find out any change in the liver which might suggest is a hepatocellular carcinoma, because one of the complications of cirrhosis is ACC. So the other things you should try to give the findings which are possible in patient who has got a underlying cirrhosis. And Dr. Basu said that ultrasound guidance, you can aspirate some fluid and send for examination. What do you expect? Suppose it's a cirrhotic ascites. What do you expect in the peritoneal fluid? Characteristics. It will be exudate or transudate?
It will be transudative type.
Transudate type, yes.
The serum albumin ascitic gradient will be less than 1.
The ratio.
Yes.
Okay. So you have done ultrasonography. What should be the next investigation? In the background of this,
we can go for CT scan evaluation of the patient. CT scan whole abdomen.
Only straight away, only you said the CT scan, or you specify
CT scan has got some markers. You see, you cannot go to CT scan by doing ultrasonography unless you have something in ultrasound which dictates you should be CT scan. If ultrasound have shown a mass lesion in the liver, which is possibly a ACC secondary to cirrhosis, CT cell would have been answered. But if it is showing a shrunken liver, ascites, portal hypertension, then I don't think CT scan should be the next investigation. What should be done next?
No, I can justify if he says that the CT scan is a very good assessment of the portal hypertension, not the cirrhosis, because you have to do triphasic, the hepatic artery phase, the portal venous phase, and the portal venous washout phase. So there you can see the difference between the normal portal vein pressure and indirect assessment, not the measurement. Indirect assessment of the portal venous pressure may be increased. Secondly, the cause of portal hypertension, as you know, we'll discuss and we'll ask you what are the causes of portal hypertension. That can be very good delineated either by CT scan or MRI. That's MRI angio. Okay, so we'll discuss that. CT scan is important, definitely. Before that, portal hypertension, stamp portal hypertension, what your investigation of choice? Only dilated portal vein cannot be a diagnosis of portal hypertension.
Endoscopic evaluation.
Upper GI endoscopy.
Upper GI endoscopic evaluation.
What do you like to see?
The varices at the esophageal gastric junction can be delineated from that.
What else? What are the things you see in upper endoscopy say that patient has got underlying portal hypertension? One is esophageal varices. What else?
There may be some ulcerations or
not ulceration. There are some other changes in the local area.
Read well sign.
What is portal hypertensive gastropathy?
Portal hypertensive gastropathy.
So it may not from varices. Directly, it may not varices bulging, but there may be changes of gastropathy, congestion of mucosa. So portal hypertensive gastropathy can be seen in endoscopy.
And also you expect from if you are being a surgeon, when you ask for upper GI endoscopy from the gastroenterologist, you always mention that please mention not only the varices which are the red sign, if there is present or not. That means that the dilated veins, the varices may bleed soon or later. So that is the red sign. And portal gastropathy is one of the hallmark of portal hypertension. Not only varices. Varices found not only in esophagus, also in stomach.
In the stomach.
Yes.
Fundal varices.
Very rarely in duodenum also. So upper GI endoscopy, yes, but still you have not diagnosed the portal hypertension. For diagnosis of portal, you have to measure the portal vein pressure. That should be your one of the investigation. Okay. And usually the portal venous pressure is not measured directly. It is the indirect way. That means hepatic venous wedge pressure.
Difference between hepatic venous pressure and wedged hepatic venous pressure.
Yes.
Okay. So your investigation is ultrasonography guided aspiration or direct aspiration of the ascitic fluid, and for portal venous pressure and upper GI endoscopy is very important here. And now you can ask for the blood investigation. What are the important blood investigation in case of portal?
The most important is
liver function test, whereby we will know the functionality of the liver.
What are the things you assess? What are the things you see in liver function test to suggest that this patient has got hepatocellular dysfunction?
So serum albumin level.
Before that, first is bilirubin.
Serum bilirubin level.
Serum bilirubin, maybe it's not very deep jaundice, but patient having hepatocellular dysfunction, there are some increase of bilirubin, which can be mixed. Either combination of both bilirubin. Then comes serum enzymes. What?
AST, ALT,
yes,
and
both may be elevated. Unlike viral hepatitis, When there is chronic hepatocellular damage, there will be some elevation. It's not that you go to the tune of 5 or 6,000 like viral hepatitis, but there will be some alteration of liver enzymes. And then come to the serum proteins. So there will be both total protein and albumin will be less. AG ratio may be altered. Albumin globulin ratio may be altered. And what about PTINR?
PTINR level will be deranged.
Yes.
Because of and that will give us the idea about the hepatic function.
Yes. So this is the global assessment of LFT. All the parameters in LFT they get altered in patient with chronic liver disease, particularly when it is decompensated. Before you go to child report plug stratification, all these parameters comes. Serum bilirubin, albumin, this all comes there. Okay.
INR so and what are the component? Serum bilirubin, INR,
serum albumin, ascites, encephalopathy, and prothrombin type.
That is INR.
That's INR. So the liver function test, this point you have to mention. Serum bilirubin, as sir said, serum bilirubin is important. Enzymes secondary evidence, but you have to, when you get these reports, you have to classify this patient as child A, B, or C, so that you can say the prognosis of the patient, or patient needs liver transplantation or like that. Okay, blood investigation. Next blood investigation is important is
CBC. Blood for CBC, complete blood count.
What do you expect?
What do you expect and point wise? You should discuss point wise.
There may be anemia, there may be pancytopenia or thrombocytopenia separately.
If you say pancytopenia, includes everything. If you say pancytopenia, all blood cell components are decreased. That is because of what?
Hypersplenism.
Yes. So once you have splenomegaly, then there is sequestration of these blood elements in the spleen. That indicates that patient has hypersplenism. If you have pancytopenia, that indicates patient has got features of hypersplenism. Okay. Any marker study is advisable on the background of patient having cirrhosis for a long time. Do you like to do any tumor marker study? Does this patient pose a risk
for HCC?
Patient with cirrhosis are at the risk of developing HCC as a complication of chronic liver disease. So what is going to happen if there is a HCC change? And that is a very important investigation in patient of cirrhosis to decide whether this patient is developing a superadded HCC. You estimate what? Alpha-beta-protein and LDH. Alpha-beta-protein and LDH are the two important markers for development of HCC in the background of cirrhosis.
Okay, so you have most of the investigation you have covered. So after this investigation, what do you offer to the patient? That means how to manage this patient.
I give you a scenario that on endoscopic assessment, there is grade 2 varices in multiple columns of varices in the esophagus, and patient has these features in ultrasonography. That patient has got ordinary cogenicity, no HCC change. What should be your treatment planning for this patient? Ascites and grade 2 varices.
Patient is having ascites along with grade 2 varices. We can go for banding therapy of the esophageal varices.
This patient has not bled. Understand? There are a number of options available for management of varices. Patient who has not bled and patient who has bled. This patient has not given any bleeding. So what is the standard recommendation for patient who has not bled and recommendation for patient who has bled?
So who hasn't bled at all, we can go for prophylactic sclerotherapy.
what are the different therapy available for varices? You see, there is an algorithm in the book. Patient who has not bled, there is a role for pharmacotherapy.
Yes, sir. We can go for
What?
No, Dr. Shah, this is totally opposite. Totally opposite. If the patient presenting with the variceal bleed, the primary treatment will be yes, sclerotherapy or banding. Number two. Number two is then you start the pharmacotherapy to prevent the further bleeding. And when the patient has not bled, but there is varices without the red sign, then the role of pharmacotherapy is doubtful, like propranolol. As these are the mentioned in the treatment of esophageal varices. And even the large varices that mean more than 5 millimeter size without bleeding or without red spot sign, the people do not treat with pharmacotherapy because there is no as such role for prophylactic propranolol therapy. So when there is bleeding, you have to do sclerotherapy or banding, and when this then start the for prevention of further bleeding, you have to start the pharmacotherapy. Otherwise, a simple presence of varices does not need any pharmacotherapy. Only regular is upper GI follow-up, endoscopic follow-up. These are the things. And other treatment is advanced treatment. We can discuss now or later when we do the surgical therapy. There is other treatment also for this surgical therapy. When this endoscopic banding, sclerosant, all failed. So
how do you stratify this patient based on the liver function?
Sir,
one is child Charcot Cook classification. That is one. What is MELD assessment for prognosticating the chronic liver disease? MELD.
So that is generally done for the.
What is MELD stands for? MELD stands for model for end-stage liver disease. MELD. What are the parameters that takes into account to calculate the MELD score?
Creatinine and
creatinine, bilirubin, and INR. These are three parameters which are taken into account for calculating MELD score. And they are saying that MELD score can predict the liver failure. And they also take into account the priority list for liver transplant is based on MELD. And now there is a modification, there is MELD-NA. MELD-NA means they take into account the sodium level also. Okay, so this is a patient has got the cirrhosis with hypertension, and you have assessed these are the patient has got ascites and varices. What should be the optimal management for this patient?
For us, for the surgeons, this type of patient with other surgical disease may present with us, like a paraumbilical hernia or gallstone disease or like that. So how do assess the prognosis of that surgical treatment in this patient? That means how child bugs criteria. Then we do not assess the MELD. We usually by CTP score, that's child Tourette bug. So how do you assess that this patient may go into bad prognosis or it is a more or less good prognosis? Tell us.
I mean, ABC. Dr. Baswas, what in the child criteria will say you, yes, this is a good risk patient, this is a poor risk patient?
Sir, the child Charcot score itself consists of the ascites, evaluation of the ascites in the form of no ascites, severe ascites, or moderate ascites, or severe ascites.
Okay, we can read that. We can read that chart. That is no
discussion. ABC.
We classify ABC. Fine. Now this patient is A. Now suppose A.
If it is A, what is the risk?
What is the risk?
patient can go in, can develop esophageal bleeding from the esophageal.
No. Try to understand. Dr. Basu has asked, this patient has got umbilical hernia, has got a gallstone disease. So if it is childpox A, B, and C, how do you predict prognosis on the background of this cirrhosis?
And Suman, when you are presenting a portal hypertension case with SIT, this is the typical case for the medical people. They are discussed. Why this scenario is discussed in surgical forum is important, because there are many patients with this disease, compensated or uncompensated, decompensated diseases, are coming to surgeons for one thing, other surgical problem. Number one. Number two, maybe some specialist surgeon for definite surgical therapy. So we have to look for this, because if you get this case in your exam, DNB exam, the most of the thing they will not discuss rather medical nitty-gritties, all these surgical nitty-gritties.
And so, another thing is the acute variceal bleed.
Yes.
Acute variceal bleed. That is another scenario where surgeon comes in.
Yes. So child day, what are the risks?
Negligible.
So child day risk is negligible.
Risk is
negligible. Risk is negligible.
That means you should be cautious. You can do a
prophylactic.
You can do a routine surgery in a patient with childpox A, taking care that this patient does not decompensate in the post-op period. So
Yes.
childpox A are the patient who can undergo routine surgical procedure, and you should have to maintain something. That means you should avoid hepatotoxic drugs, and you should keep the patient adequately hydrated, and you should maintain the vitals, correct anemia. So, but child B, C are the category of patient where there is high risk for post-op hepatic decompensation.
See, child B, what are the risk? What is the risk? Almost 50% chance of dying or going to the liver failure, 50%. And child C, usually other surgeries avoided, straight send this patient for the liver transplantation, unless there is any emergencies surgery like that. Otherwise, child C usually don't tolerate any surgical procedure except liver transplant. So
we can discuss about the variceal bleed. Dr. Basu, we can discuss management of this patient coming with a suppose this patient has come to you with a acute variceal bleed.
Yes.
So how do you proceed?
This patient, if comes with acute variceal bleed, I will examine the patient and evaluate the patient, and I will go for resuscitation of the patient in the terms of giving fluid and also blood transfusion, whatever blood transfusion in the form of PRDC, and if required, platelet or FFP, and then.
So resuscitation with IV fluid and blood transfusion. Now next is
prophylactic antibiotic coverage. Then I will see esophageal upper GI endoscopy. I will do to see where from the bleeding is occurring, and I will go for banding therapy.
Before that, there are some other pharmacotherapy which are usually done in medical ward.
Yes.
What?
Injection talipressine or injection octreotide. It can be.
Go slowly. There are some for section. Okay, these are injection vasopressin or is analog talipressine. Okay, these are very effective drugs. They can control a minor bleed, or you can use sumatriptan analog like octreotide. So there are two important drugs which can control the variceal bleed by just medical means. Suppose with this drug also patient is having a situation of a massive variceal bleed. What is the next step?
Then endoscopic evaluation.
Patient cannot be taken to the endoscopic suite. Any other measure that can be done in the medical ward itself?
By giving you things to
tamponade effect. So this is a breathing procedure. If the patient is having such severe amount of bleed and cannot be taken for endoscopy, there is a role for decompression by Sengstaken Blackmore tube. Okay, where you have both esophageal and the stomach balloon.
Yes.
And then what is the endotherapy? So next should be endotherapy. What is endoscopic therapy for such acute variceal bleed?
Banding.
One is banding. What else? What are the different ways you can control bleed by doing endoscopy? One is bending.
Another is sclerotherapy. But
another thing is one is sclerotherapy. But another substance which is not exactly called as sclerotherapy, there is something else which is known as this cyanoacrylate glue.
In case of gastric varices bleeding, we generally give cyanoacrylate.
So suppose now the situation is endotherapy has also failed. Even with endotherapy, patient is bleeding massively. What should be done? The next step.
Then some emergency surgeries can be done.
Like
one is shunt surgery, another is non-shunt surgeries. Non-shunt surgery is revascularization surgery.
No, before that, now you see with interventional radiology, these surgical shunts are not the next option. Now TIPS is another important interventional radiological procedure which can be done in acute setting also.
Yes, sir.
So before you go for a surgical shunt, the next option in uncontrolled bleed should be a TIPS. What is TIPS?
Transjugular intrahepatic portosystemic shunt.
What is that procedure exactly?
Sir,
what is done in that?
In that case, via the jugular vein, we approach the IVC and directly to the via the hepatic vein, we reach the hepatic parenchyma where a shunt is created between the portal vein and the thereby causing decompression.
Yeah. So, what is that shunt placed?
In the at the sinusoid.
What is that shunt? The shunt placed is a metallic shunt, expanding metallic shunt that creates an association with the right branch of portal vein and the hepatic vein. Tips.
1B এই দিকটায় একদম গেটের কাছে থ্যাংক ইউ
Yes. So tips
is there, and other these adjust surgical therapy are not nowadays not done usually. So now tell us if you want to manage this patient with portal hypertension, what are your surgical options for portal hypertension? Before that, you will say us what are the causes of portal hypertension. Then we can categorize the surgery. What are the causes of portal hypertension? Basically, you have to know that portal hypertension due to this thing, liver cause or non-liver cause.
So it can be portal hypertension can be due to some pre-hepatic reasons, some hepatic reasons, some post-hepatic reasons.
No, better as you are PG student, better you have a pre-sinusoidal, sinusoidal, post-sinusoidal. Because pre-sinusoidal, there are extrahepatic and intrahepatic too. Okay. So first cause is pre-sinusoidal. Extrahepatic, what is that? What are the cause? Extrahepatic?
Portal vein thrombosis or
portal vein thrombosis.
Or any tumor developing in the pancreas leading to obstruction of the portal vein or pancreatitis.
Usually obstruction by tumor does not cause portal hypertension. Okay, because it takes long time. Congenital absence, congenital atrophy of the portal vein, that can cause. Okay.
Or portal vein thrombosis.
Thrombosis is common.
We can occur following neural sepsis. Neural sepsis can cause portal vein thrombosis.
Yes. And
what is sinistral portal hypertension? What do you mean by sinistral portal hypertension? Sinistral portal hypertension is a left-sided portal hypertension which occurs in splenic vein thrombosis. Okay, so this is manifested as mainly as gastroesophageal varices. Distal portal hypertension is the occlusion of splenic vein. The main portal vein is intact. Okay.
So gastric varices mainly the
gastric varices. There is an explanation for higher incidence of esophageal varices in the lower end of the esophagus. Do you know the explanation? I could find in a surgical book. Why these varices are more predominant in the lower esophagus? Because throughout the esophagus there is esophagus a photosystemic connection. The reason is in the upper and mid thoracic esophagus there is communication between the esophageal vein and the systemic veins in the thorax by perforating veins. It said that this communication decompresses the veins of the upper esophagus. But in the lower esophagus, there is no such perforating veins. So the burnt of these portal hypertension falls in the lower esophagus. That's why the varices are more common in the lower esophagus than the upper esophagus. Upper esophagus, there is a communication between the systemic veins. Okay. We discuss about the transplant or shunt indications.
See, the only say portal hypertension does not need liver transplantation, other surgical options.
I mean, the other
common is chronic liver disease. Common is chronic liver disease transplant.
End-stage liver disease.
So, so I don't think the discussion of different surgical procedure for portal hypertension is relevant nowadays. Most of them are not done. Very rarely done. Only DSRS you can mention, but not in the other specialized center.
This is done. The indication now is if the tips has failed, the primary shunt procedure is tips, but in some situation the tips may fail for in long run, and then the next is also tips revision, and then if that doesn't work, then there is a role for doing some form of shunt procedure. Okay. So again, if you say the shunt procedure, there are two types of shunt. One is selective shunt and non-selective shunt. What is a selective shunt?
So in case of selective shunt, a little bit of hepatopetal flow is maintained.
Yes.
And in case of non-selective shunt, that is not done. So
that means this is
yes,
there is a cutoff. So you do either end to side portacable shunt, or do a wide side to side portacable shunt when the whole portal blood is diverted out. Okay.
That is non-selective.
Yeah.
And what are the selective shunts?
Selective shunt is like Warren shunt or Anukuchi shunt.
Warren shunt is distal
splenorenal shunt.
Yes.
And Anukuchi is coronary vein and IVC shunt.
Coronary vein?
And IVC.
Coronary vein is the left gastric vein.
Left gastric vein with the IVC.
So, other points discussed is liver transplantation. Liver transplantation should be another class, no?
Yes. So, basically, you have to present this case well, stating the presentation with stigma of chronic liver disease, and then you come to diagnosis like this, the presence of decompensated liver disease with portal hypertension. And then you have to justify the diagnosis, justify the portal hypertension, and the current approach for investigation. Okay. Any other point, Dr. Basu?
No, it's covered well. Other the questions from any students?
Any chat box?
No, nothing in the chat box.
Okay. Thank you, Dr. Basu.
Thank you.
Thank you.
Thank you, sir.
Thank you.
Thank you, Suman. Thank you.